If health is wealth, then AI is helping us get richer. From improving clinical care to empowering personal health monitoring, AI-driven solutions are taking part in changing the way we get and stay healthy. AI has found itself into different aspects of health and wellness. From molecular diagnostics and genetics to radiology and orthopedics and even mental wellness, AI is revolutionizing healthcare services in ways we can never imagine. AI's role in the Philippine healthcare system continues to grow, as medical services are pushed to be better and more accessible to the Filipino public.
I'm supposed to give an overview on artificial intelligence in health, but I'll be focusing on a specific aspect of health dealing with medical decision-making. The outline of my talk, I'll talk briefly an overview of the realms of artificial intelligence in healthcare, and then talk about how we push it through research by giving a framework for research on AI in medical decision-making. I'll give an example of a study we did in a rural and remote area in the Philippines, and then move on to moving forward. So, starting with the realms of artificial intelligence in healthcare. So, healthcare is mainly about diagnosis and management. And most of our AI applications deal with support for diagnosis, whether it's genomics or imaging, and management, whether it's surgery, choice of medicines. The three strong areas I've seen in the search for literature a few days ago was in analysis of imaging, CT scans, MRIs, X-rays, risk prediction in real life with learning. So estimating the risk of patients for events as they come in, and decision support, helping physicians, nurses, midwives make decisions on behalf of patients. There are also administrative issues such as data processing for pandemic identification and monitoring, for monitoring health finances, and also patient assistance, helping them make appointments, decide when they need to go to the emergency room or not. Whatever realm of AI or investigation, the question you'll always come up with is, what's the evidence that we should apply this particular technology you're advocating? So we go to part 2 of my talk, a framework for research. I'm going to show you the 3 most common research questions in clinical decision-making, especially in artificial intelligence. They're questions on diagnosis. Does the patient have this disease or not? Prognosis, what's going to happen to this patient in the future? And effectiveness, what can we do to change the prognosis of that disease? Whatever research question we ask, there are 3 essential components, which I'm sure many of you have studied already. What's the population you're studying? That's P. What's the exposure or AI technology you're evaluating? And what's the outcome that you are targeting? For diagnosis, for example, the syntax would be in patients with a condition P, how accurate is the test E in diagnosing disease O? For example, among diabetic patients, how accurate is AI evaluation of retinal photographs in diagnosing diabetic retinopathy? So, link's not working, but there's an actual study on this. For prognosis in patients with a particular condition, how accurate is AI in predicting the outcome? A recent study evaluated among diabetic patients, how accurate is AI in patient assessment to predict dementia in the next 5 or 10 years? And for effectiveness questions in patients with a particular condition, how effective is the AI technology? And there's an E2, a control group. in preventing events in the future. Here's a recent study among patients for surgery under general anesthesia, how effective is a chatbot compared to a nurse in reducing perioperative anxiety. So the appraisal rules for evaluating studies on diagnosis, prognosis, and effectiveness for artificial intelligence are no different from whether we're evaluating simple tests or treatments and whether you're evaluating artificial intelligence. What differs will be the reporting standards. So for the population, describe the context, describe study population, describe the users. For example, what's the clinical setting? Is it rural or urban, highly advanced or delayed settings? And what specifically is the problem that you're trying to solve? The population should be described. What are the patients being subjected to this study? And who's going to be using this AI? Will it be doctors, nurses, midwives, or patients? For the AI technology, we need to describe the algorithm being used and the version of that algorithm. We need to describe the input required and the output that's expected from these algorithms. We also need to describe areas where there is AI-human interaction. These first two fields, the P and the E, help us duplicate the technology that's being presented. No? One study is not enough. People have to show it works in other areas. In trials, when you're evaluating effectiveness, you need control groups and you need to describe what's the usual care before the AI came. No? And what does that AI add? So a usual design will be AI plus usual care versus usual care alone. And then, most important, the outcomes. There will be surrogate outcomes, just intermediate measures. For example, was the AI technology acceptable? Is it feasible? What were the failure rates when it failed to operate? And even when it succeeded, what were the error rates? But ultimately, we need to show clinical outcomes. And this is where we've failed a lot. Patients, we need to show, need to be better off. They need to feel better or live longer. Or even when the outcome is unchanged, they don't feel better, they don't live longer, but we must show we can achieve the same outcomes at lower cost or at lower effort, so higher efficiency. So I'm now going to move to an example, which is part 3 of my talk. It's a study we did on a decision support tool for barangay health workers. The clinical context is, well, barangay health workers can be physician extenders, but they are not trained. They are usually political appointees by the mayor. No? Study population is a rural area, Samal, Bataan, and a remote area in Bulusan, Sorsogon. The users were healthcare workers, but mostly the barangay health workers. The input data was a diagnosis or a symptom of a particular patient. The algorithm used was from up-to-date software, and the output was patient education material that they could use. So in lay's language, and this would augment what physicians do. Now, physicians rarely have time to explain, but this is something barangay health workers can do, help explain. AI-human interaction is tremendous here, and I'll show you. This is a hierarchy of information services that need to be processed to come up with decision support. So at the bottom would be original studies, a single publication on a specific question. I'll do an example for what's the best treatment for COVID. If you did a search for that to help in your decision, you're going, and I did this a few weeks ago, you're going to find 5,000 trials on COVID-19. And you're going to evaluate each one. Here are some examples: nirmatrelvir for vaccinated and unvaccinated adult outpatients, effect of ivermectin, and others. So that's really difficult. So there needs to be a second intervention, processing these original studies, by coming up with systematic reviews. So systematic reviews review several original studies and summarize the results. So example would be a meta-analysis. When I searched for that a few weeks ago, I found 1,100 summaries. Napakarami pa rin, no? And here are some of those studies: hydroxychloroquine, nirmatrelvir, and ivermectin. We had put so much hope on meta-analysis would translate to medical decision-making, but it's still a lot. So going through original studies is like drinking from a fire hose. You're gonna die. But going through systematic reviews is not a lot better. No? You can still drown. So a third level would be to come up with summaries or guidelines. No? It combines several reviews to come up with the bottom line. How should you manage a particular patient? So when we looked at practice guidelines for COVID-19, ang dami pa rin, 540 guidelines. So still a lot to process, and here are some examples. So while it's now sips of water, still a lot of glasses to drink from. But there are now simpler representations of guidelines through decision support tools, and this is what we evaluated in our study. We published in BMJ Open Quality, Feasibility, Acceptability, and Impact of a Clinical Decision Support Tool among primary care providers in an urban, rural, and remote area in the Philippines. So we went to Bulusan, for example, taught the barangay health workers how to use up-to-date and how to come up with educational material for their patients. No? And we found out that it was acceptable to them and the information was useful. Shameless plug here. So I now work for the Health Equity Research Foundation of St. Luke's. We give grants for research that address inequities in healthcare. So if your AI technology helps address these inequities, St. Luke's offers funding for 10 studies every year. You can visit our website at here.stlukes.com.ph. This was my retirement plan. Moving forward, for the study, there was no control group, but we intend to move forward. We need a control group. Our outcome was just surrogate, acceptability, and feasibility, but we need to demonstrate that this decision aid can actually lead to better patient care and healthier patients. Now, moving forward, in that way, we can also move forward by advancing decision support from summaries to systems. Now, here's an example of an electronic medical record we're evolving, developing. If you fill it up, the doctors here know S is yung nararamdaman ng patient. No? So patient with cough, sore throat, and fever. Objective is your PE, so you put in the blood pressure, heart rate, the respiratory rate, and temperature. There's tonsillar congestion, clear breath sounds, and the labs show an oxygen saturation of 98, maganda naman, but RT-PCR positive yung patient. So you put in the diagnosis, mild COVID-19, hypertension. You prescribe nirmatrelvir with ritonavir and continue the losartan for the hypertension, and the patient's also on simvastatin for high cholesterol. So under a systems approach, you don't have to look for the evidence. The evidence finds you. And if you see here at the top, yung U with the number 2, there are 2 alerts as you are seeing the patient. And if you click that, one alert is it tells you the treatment with COVID-19 specific therapies, indications for treatment, and you can scroll down. There's therapies of limited benefit, therapies that we do not recommend, so guidelines na. Click therapies we do not recommend. There's hydroxychloroquine, ivermectin, etc. At the bottom, you have vitamins and supplements. If you click it, you'll see why they don't recommend vitamins. And then there's a second alert. You're giving the patient simvastatin and nirmatrelvir, and it's warning you that they are interacting. So if you see risk rating is avoid combination because nirmatrelvir may increase the serum concentration of simvastatin. It's a major interaction, so you need to either stop the medicine temporarily or shift to something else. So those are systems, which is now drinking on the go. Instead of you finding the evidence finds you. Instead of you studying just in case you see a case with this disease, you see the evidence just in time. And it sticks in your mind because it helped you manage a patient. It's not theoretical knowledge. It's actual knowledge that you can use. So these are the levels of information services. As you can see, we need to move up to systems in the future. And I guess the question in many people's minds, I searched this last night. Can artificial intelligence replace healthcare workers, doctors, nurses, midwives? There were 19,000 hits. So a lot has been written about it. Is technological singularity in health possible? Yun yung may superior intelligence na, no, that learns on its own, that develops and multiplies on its own. But based on what I've showed you, just this simple thing from studies to a clinical decision involves so much. The studies, you need to remove false data, and AI is, well, very poor in distinguishing true from false data. And that entails, developing systematic reviews. Again, human intervention, numbers are not decisions because we have values and preferences. And you need to subject these reviews to these values and preferences to come up with summaries or practice guidelines. And then these guidelines need to become algorithms for decision support systems. So artificial intelligence, in the end, you need to talk to the patient and find out their own preferences to come up with a decision. So artificial intelligence, in my opinion, we're far from it as the single tool for medical decision making. However, we can look at it less as artificial intelligence and more of augmented or assisted intelligence, where it will help doctors, nurses, and midwives in improving the quality of care they give to patients. So that's moving forward in terms of decision support for management. But also moving forward, as we thought about artificial intelligence, something bothered me. It's a 1,000-mile journey. And that journey should begin with the first step, the health information system. We don't even have an health information system after talking about it for 15 years. No? It's actually mandated by the Universal Healthcare Law. No? The health information system shall be developed and funded by the DOH and PhilHealth within 3 years from passage of this law. No? 2019 na yun, wala pa din. Hindi ba? Kasi without the information system containing the diagnosis, management, patient data, how do we even move to artificial intelligence? So we need to take that crucial first step. And in my opinion, when we do, then there will be an avalanche of improvements, and that avalanche will be headed by AI. So, in summary, I've talked about the realms of artificial intelligence, ranging from diagnostics to therapeutics. The framework for research and the reporting standards when we're studying AI, because this is needed if we're going to convince policymakers that they will improve healthcare. I've offered an early example in primary care, the decision support systems, still a long way to go. And moving forward, I mentioned the first step is developing our own basic health information system. I hope that was helpful. Thank you for your attention.